could potentially be a long one, but I'm just wondering, something that's come up a bit from the screening last night and today, why do you think the UK medical establishment is so keen to suppress publication of the evidence of successful alternative or integrative treatments, like the example you gave about the patient that was so successful with the mistletoe? Why do you think the medical establishment want to suppress that, and do you think that's the case in other countries?
Well, I have to be careful. I'm sitting in two sides of the of the fence. But no, I think from our point of view, it was the hospital consultants were surprised that they couldn't publish it so easily. And retrospectively, it was actually good. I always like to see that as good challenges, because we had to put so much effort into publication. It was very water sound. It was really well done afterwards. So I think in order to publish something really effectively on the complementary side, you need to be doing a very good job. I think, why is it different in other countries? I don't think it's easier in America. I think the German climate or the Central European climate is easier, and that has to do because I think there are much more consultants, oncologists, and physicians involved in complementary or in integrative treatments packages or contexts, and so that you have various big hospitals run on that basis makes a big difference. Here, it's mainly GPs. Hospital consultants or clinicians are very, very restricted what they can do and what they in the climate where they work, and therefore you're not getting many people involved in that. So the fact that I'd like to see an oncologist sitting here talking about integrative approaches in the hospital, but that will be very, very difficult to get in the UK. With the mistletoe, it's very straightforward. I think the big knowledge and the big experience are in the hospitals, and a city like Aberdeen in Germany will have 3 practices like ours. That's just would be the average. So it's just much wider spread, and it's easier to pick it up. And it's so much more difficult to do that over here.
But you say that, but what is the bottom line?
It's complex. I think it's very complex, and that it's multifactorial. There's not just one reason for that one. One of them is that you have a clear distinguish between primary care and secondary care here in the UK. And in Germany, you don't have that one. You have an NHS system, which is very evidence-driven, NICE guidelines-driven, and so on. Germany, you have, I think if insurance companies see that the patients they are supporting find this approach better, if it's cheaper and it's effective and patients are more happy, they're happy to pay for that one. That's a very different climate than you have over here. So the contexts are very different. And this is just one aspect. I think there are very many more.
You said this afternoon actually, that the mistletoe is administered subcutaneously and intravenously, and also by mouth with drops. Okay, what's the effect of the capsules, the mistletoe capsules? Is there any mistletoe capsules at all?
Not to my knowledge at the moment. There might well be, but not that I know of.
Okay,
honestly.
But will it have any effect, you think?
You see, there are 2 areas you can look at from the purely lectin, viscotoxin, and the material substances which are in the mistletoe. We know very little how much the whole absorption rate orally is real, what's really happening there. So to say how much viscotoxin, lectins, and other substances are actually absorbed is a big question. Also how much you can actually get there, because it is dose related, the responses. What I was surprised over the last years, I mean, I'm fairly mainstream trained, but I discover more and more that the immune system is not equal immune system. So an immune response via the skin is a completely different one via the infusions, completely different via oral, and again, differently when you go inside the tumor. You start tackling different immune responses, different aspects of the immune system, and the more you know, the more questions you have. I start more and more combining the different approaches and find out what's best for the patient.
Just a quick question for Jenny. Just a question on sugar, actually. I'm trying to avoid it, but at the times when you may need to sweeten something, I don't know, between xylitol, stevia, maple syrup, agave, and so on, which is a good alternative if you need to obviously, sweeten food.
Yes.
Yeah.
I've had this discussion with Zandria Williams, who's at the back there, quite a lot, and very much xylitol when it comes to baking,
Right.
which is a sugar alcohol.
That doesn't spike the insulin or sort of
No, it
send
doesn't.
things.
No, it doesn't.
Yeah. Okay.
Some people advocate stevia. Personally, I think it's got a little bit of an aftertaste.
Right. Do you know which brand is good? Because I know the real stevia is like green and tastes very metallic, and that you get these sort of processed stuff in Planet Organic or Whole Foods. I don't know if you know a good brand, which is a good.
It's not what I tend to go for xylitol
Right.
as a preference.
This is a question for Barbara or Ted. I've been reading about recent evidence for actual muscle mass being a protection against cancer. They did a trial, I think, with men who did weightlifting and found that they were much less prone to get cancer, and also that people who have good muscle mass and increase their muscle mass have got much more chance of surviving. I wondered if you could comment on that.
I'm not familiar with that particular study, but as we were both saying, we think that muscle mass is associated with physical activity, and physical activity has got so many different ways of helping your body perform and function properly. The work that I do with people undergoing cancer treatment is very much about maintaining muscle mass in a way that doesn't deplete energies while you do the exercises. So a lot of the mindfulness, a lot of the very, very slow movements that you made us do earlier, really building the muscles from the inside without using the momentum and without dissipating energy.
I'm not familiar with the study, but I think there's a tendency for us to think that muscles do nothing but just move our skeleton, and that's it. Muscles are metabolic organs. They process, they store energy substrates, and I think it would be very difficult to tease out the real truth here, because as people get stronger, they're more able to do things, their mood will improve, stress will reduce. There's a whole panoply of things going on, which may be initiated through becoming stronger, increasing muscle strength. So I don't think it's surprising. So it's very credible what you say.
Question for Stefan. Hello. I just wanted to ask about the mistletoe. I've been reading about Herceptin, and that mistletoe can sometimes be a natural substitute for Herceptin, and it's always a bit dangerous to say anything is a substitute for something allopathic. But I just wanted to find out what your thoughts are about that, and also the fact that Herceptin is now being administered subcutaneously, and so I'm interested, now that you've said that the immune response can be different subcutaneously than it can be intravenously. So that's another interesting area that
we don't have any evidence, at least which I know of, that we should use it as substitute, or that that there's any interference between Herceptin and mistletoe. So the question for me is not about substitution. It's more the question what is in the overall spectrum of possibilities, and what the patient, the situation, the individualization in it, what has its rightful place and when. So I have not seen, if it would be just really the same doing, I haven't seen it with the patients I'm involved, and therefore I would not advocate it as such. I would see it in the same way like I would look at chemotherapy, other chemotherapies, or radiotherapy options, depends on.
Is it good for bone metastases, mistletoe? I was reading something about that as well.
The knowledge about the details on how we can manage to get the mistletoe impacts on such questions about is it good for metastasis or bone-specific ones is very, very difficult to answer. On a clinical perspective, yes. What I see with my patients and so on, I can fairly feel very confident on that one. But from a scientific background point of view and the research background.
I'm having mistletoe therapy free on the NHS at at the London Hospital for Integrated Medicine at Great Ormond Street. You just need a letter from your GP to refer you. So I just want to throw that out there. I'm a herbalist and I'm taking mistletoe as a herb as well, because the Iscador that I'm taking from the Integrated Hospital is a homeopathic preparation, isn't it? So I'm interested, I don't know if you know anything about the herbal medicine application of mistletoe, do you?
I think the herbal medicine of mistletoe, are you taking as drops from Veleda or just...
I'm taking a tincture.
A tincture from which company?
I normally order from Panacea.
Okay, but I have had very interesting conversations with the guys up in the Rowett Institute, the International Nutritional Institute in Aberdeen. And they, 15 years ago, did enormous amount of research on lectins and wrote quite some papers about it. And they were fairly world leading on the lectins, including mistletoe lectins. And they did looked at phytotherapy and had lots of animal experiments and so on. The outcome of all of that one is that if you use it as herbal remedy, there will certainly be some impacts on that one. The lectins were absorbed, the viscotoxins are absorbed, and so there will be some elements in there. Clinically speaking, as a doctor, it's just very, very difficult to control and to see how much and what's happening. Therefore, the injections and the IVs and intratumors, where you have all standardized properly ampules. We know exactly in each ampule how much is in, what's in there, and it's fairly standardized, so you can better predict and control and repeat.
Interesting what you said about the cytotoxicity is more prevalent in the actual herbal medicine.
Yes.
So I'll be getting that from my tincture.
Yes.
And then increasing my immune response, etc., with the homeopathic Iscador. So yeah,
and
it's a nice combination.
Yeah, and I certainly had patients who have been on mistletoe, subcutaneous and intravenous, who went to teas and had some strong, similar reactions like you could get, hypersensitive reactions like you could get with the subcutaneous injection. So immunologically speaking, something is happening. It's just that it's more difficult to handle it and predict it and to control it.
Thank you. I bought a book the other day, and reading it, there was a little statement in there: you can't have a dialogue with nonsense. It's really delightful today that we've been able to have dialogues with everybody that's spoken, so that's really good. But also I'd like to tell you one other little thing, and that is the fourth operation of making linen from flax is called heckling. And that is where the political word heckling comes from. So what you're actually doing is you're combing all of the dross and the rubbish out of the fibres. So that's what you must all do. If you hear anybody from the National Health Service or politician talking rubbish, heckle them until they make sense.
Thank you, Derwin.
It's an exercise question. I run a running group, and one of the ladies who comes has just been diagnosed with breast cancer. Are there any restrictions on the amount of running she should be doing, or any advice in terms of what I should be giving her in terms of a program?
I don't know specifically. I think it depends, is the answer. One of my main challenges is teaching yoga to people who have been very active in yoga. There are some very, very strong schools. And the risk there is that psychologically it becomes an obstacle rather than something that can help, because they keep comparing themselves to the older self before the operation, before chemo, before radio, and they feel inadequate. So I don't know, I think you need to work with the person on accepting the new limitations that the therapy is bringing up and working around it and realigning with a new self without pushing herself too hard. That is the most important thing. Apart from that, I wouldn't say that there is a physical limit.
In helping people exercise, I mean, obviously we're guided by evidence, but an awful lot of it is observation. How is this lady coping with what she wants to do? Does she warm up properly? Does she cool down properly? May I ask how old she is, roughly?
Mid-40s.
Mid-40s. in which case, and she may well be on hormone therapy? Something you should find out, because in fact, if she is and she's running, that's a good impact exercise, as long as there are no bony metastases, and in which case the impact of running and long duration running could be deleterious.
I've got bone metastases and I run about a mile every day.
Yes.
And I haven't got any pain in my metastases anymore, and I really feel good, and I really enjoy it. So.
Yeah, I mean, at a conference the other day, I asked one of the UK experts the role of exercise in patients with bone metastases, and he just complimented me, saying it was a good question, and the quick answer to it is that there is no evidence whatsoever, and that one would actually tend to treat patients with metastases as you would with a patient with osteopenia or osteoporosis, which would be to avoid impact. The other thing I would advise you, if I may, is to incorporate into your exercise program some strength training for the lower limbs, so that the joints are absolutely stable and you're absorbing that impact.
Could I just add to this dialogue that's just been happening, and that was something that was mentioned this morning, about that some of the so-called bony metastases are actually calciums being borrowed from the bone for use elsewhere in the body. And so there could be some overdiagnosis of bone metastases, which we could be getting very worried about, when in fact what's happening is those low density images on radiographs are just low density areas. And impact exercise is going to help with the remineralization of bone, because of heel strike really benefits that.
Big round of applause, please, for our expert, who's done a fantastic job again.